We are looking at a piece today from My Adrenal Life, specifically digging into this blurry, often incredibly frustrating line between depression and physiologic low cortisol. The premise here is that patients with adrenal insufficiency are frequently misdiagnosed with depression or anxiety. We should establish right away, for anyone navigating this, the My Adrenal Life Facebook group is the hub for this entire conversation. That is where you can read the full articles we pull from, and it acts as a very specific, warm community focused entirely on adrenal insufficiency, education, and support. Because when your body feels like lead, when your mind goes completely flat, when simple tasks suddenly require this monumental effort, trying to untangle what is emotional from what is hormonal is a massive burden to carry alone.
That burden is almost heavier than the physical symptoms themselves in a way. Because before anyone actually explains the biological mechanism to you, you spend months, often years, living in this profound state of self-doubt. You read the symptom list for depression, and on paper, it matches. You have no energy, you cannot focus, your sleep is wrecked, your appetite is shifting. But internally, the lived experience feels fundamentally different than what you understand depression to be. You still have the desire to participate in your life, but your physical battery is completely disconnected. The disconnect between what you feel and what a standard intake form suggests leaves so many people feeling entirely dismissed by the medical system.
That disconnect is the core problem. The article points out that depression is a highly serious, valid mental health condition requiring specific care. Physiologic low cortisol is a serious endocrine condition requiring specific care. The issue is the overlap. They share so much surface-level real estate that the underlying biology gets completely ignored.
Actually, calling it surface-level real estate almost understates how identical they can look to a clinician moving quickly through a 15-minute appointment. If a patient sits down and says they are exhausted, struggling to concentrate, and losing weight, the immediate clinical reflex is to look at mood disorders. Research from the European Journal of Endocrinology found that over 67% of patients with adrenal insufficiency consult at least 3 physicians before getting a correct diagnosis. And nearly 70% are initially given an incorrect diagnosis, with psychiatric or psychotic causes being the label in over 40% of those cases. That is a staggering number of people being told their physical endocrine failure is actually a mental health crisis.
40% handed a psychiatric label when their adrenal glands are failing. That immediately reframes the stakes here. If you are sitting in a doctor's office and you lack the vocabulary to say, this is an endocrine issue, you will just agree with the depression diagnosis because it is the only framework being offered.
Or you agree because you actually are depressed by the sheer exhaustion of living with an undiagnosed, untreated chronic illness. The emotional strain layers directly on top of the physiological depletion. But the tragedy is that treating the secondary emotional strain with antidepressants or standard mental health therapies will never, ever replace the missing cortisol. You can do cognitive behavioral therapy for years, but if your adrenal glands or your pituitary gland have stopped signaling for cortisol production, your cells are literally starving for a hormone required for basic human function.
Let us break down what cortisol actually does, because the cultural understanding of it is entirely broken. People hear cortisol and they think stress. They think of it as the villain hormone that causes belly fat or anxiety. But this article reframes it completely. Cortisol is not just a stress response. It is an essential operational hormone.
The cultural branding of cortisol as this toxic stress chemical has done so much damage to how we understand human biology. Cortisol is the molecule of life. Without it,
You cannot maintain your blood pressure. You cannot regulate your blood glucose. Your immune system loses its signaling pathways. Your metabolism stalls. It operates on this beautiful, complex circadian rhythm, peaking in the early morning to wake you up, slowly tapering off throughout the day so you can eventually sleep. When we talk about low cortisol and adrenal insufficiency, we are not just talking about a slight dip in energy. We are talking about the total disruption of the body's primary pacing and survival mechanism.
This leads directly into the different types of adrenal insufficiency mentioned in the piece: primary, secondary, tertiary, and steroid-induced, because the flavor of the depletion changes depending on where the system is broken. In primary AI, Addison's disease, the adrenal glands themselves are damaged. You lose cortisol, but you also lose aldosterone.
Aldosterone is the crucial dividing line here. It is the hormone that tells your kidneys to hold on to sodium and excrete potassium, which directly maintains your blood volume and blood pressure. When you lose aldosterone in primary AI, you are dumping sodium. You become chronically dehydrated. Your blood pressure tanks. This gives clinicians very concrete, measurable physical red flags, if they know to look for them. But in secondary and tertiary adrenal insufficiency, the adrenal glands are physically fine, but the signaling from the pituitary or the hypothalamus is broken. In those cases, aldosterone production is usually preserved because it is regulated differently.
So secondary and tertiary patients might not have the classic Addison symptoms, like severe salt wasting or the famous hyperpigmentation. They just have the profound, crushing fatigue and cognitive slowing from the missing cortisol.
Exactly. Wait, actually, let me clarify that. They do not just have fatigue. They have a pervasive physiological slowing that looks incredibly similar to psychomotor retardation, which is a classic symptom of major depressive disorder. Their thinking slows down, their speech might slow down, they lose their appetite. Without the glaring neon sign of plummeting sodium or hyperpigmentation, a clinician looks at the slowing down and naturally assumes depression. The historical medical literature actually backs this up. Studies going back decades show that apathy and negativism are present in up to 80% of Addison's patients before treatment. The psychiatric manifestation is not a rare quirk. It is a core feature of the brain being starved of glucocorticoids.
But wait, I want to pause on that. If the brain is starved of glucocorticoids, and it genuinely creates apathy and negativism, then isn't the depression diagnosis technically accurate? It sounds like you are saying the low cortisol literally causes a depressive state. So treating them for depression does not seem like a total misfire, just an incomplete one.
I do not think that holds purely from a treatment perspective. Calling it depression implies the pathology originates in the brain's emotional or neurotransmitter centers, serotonin, dopamine, norepinephrine, and that standard psychiatric interventions will resolve it. But this is an endocrine failure manifesting with psychiatric symptoms. The brain actually has a high density of glucocorticoid receptors, especially in the hippocampus. When cortisol is absent, the frontal circuits literally cannot function properly. It alters reasoning, thinking, and executive function. If you give that patient an SSRI, you might slightly blunt the emotional distress, but you have done absolutely nothing to address the frontal circuit dysfunction caused by the missing hormone. It is like putting a fresh coat of paint over a rotting foundation. The apathy is a symptom of starvation, not a mood disorder.
That distinction, starvation versus mood disorder, is incredibly sharp. It explains why patients in the My Adrenal Life article described their experience not as emotional sadness, but as physical depletion. Less hopelessness, more inability to function. Less loss of interest, more lack of capacity. They want to do things. The desire is intact, but the machinery will not turn over.
That is the exact phrase I hear from patients over and over. I want to go for a walk. I want to see my friends, but my body feels like it is made of wet cement. Classic clinical depression often involves anhedonia, a true loss of interest or pleasure in activities. The desire itself evaporates. In adrenal insufficiency, the desire often remains intensely, frustratingly present. You are trapped inside a body that simply refuses to execute the commands. And the tragedy of misdiagnosing this is the timeline. The data shows 20% of patients suffer for more than 5 years before someone finally tests their cortisol.
5 years of believing your mind is broken when your adrenal glands are just failing. And let us fold in the steroid-induced adrenal insufficiency piece here, because the article notes this overlaps with secondary and tertiary forms. This happens when someone takes synthetic steroids for asthma or autoimmune issues, and their own body just stops making cortisol because it senses plenty in the bloodstream.
The feedback loop shuts down. The hypothalamus and pituitary go quiet because the synthetic steroid is doing the heavy lifting. The danger comes when that patient tapers off the synthetic steroid. Their internal HPA axis, the hypothalamic pituitary adrenal axis, can remain asleep for months, sometimes longer. During that withdrawal and recovery phase, they plummet into the state of profound cortisol deficiency. And again, what does that look like? Lethargy, joint pain, loss of appetite, brain fog. A doctor might look at that and say, you were just stressed from the tapering process. Maybe you were experiencing some depression. No, they're experiencing acute hormone withdrawal and secondary adrenal insufficiency.
How do clinicians actually separate this out? The article lists 5 specific patterns they look for. Laboratory testing is the first one, but obviously context matters entirely. You cannot just draw a random cortisol level at 4 in the afternoon and make a ruling.
A random afternoon cortisol draw is almost worse than no test at all because it provides false reassurance. Cortisol is naturally supposed to be low in the late afternoon. If a doctor sees a low number at 4 p.m., they might say, looks normal for this time of day. To actually see the dysfunction, you have to look at the peak production time, which is usually between 7 and 8 a.m. And even then, a baseline morning draw is often not enough. You need the ACTH stimulation test. You administer synthetic ACTH to the patient, which is the pituitary signal to the adrenal glands. And you measure if the adrenal glands actually respond. If they do not pump out cortisol in response to that loud chemical shout, you have your diagnosis.
The second pattern they mention is blood pressure and volume status, specifically orthostatic symptoms. That moment when you stand up and the room goes black for a second, that is a mechanical failure, not a mood issue. That is a mechanical failure, not a mood issue.
It is a cardiovascular failure driven by an endocrine deficit. Cortisol helps maintain vascular tone. It helps your blood vessels constrict when you stand up, so gravity does not pull all your blood into your legs. When cortisol is extremely low, that vascular tone is lost. You stand up, your blood pressure drops, your heart rate spikes to compensate, and you feel dizzy or faint. Primary depression does not typically cause severe orthostatic hypotension. If a patient comes in reporting profound fatigue and they also mention they have to hold on to the wall every time they get out of the chair, the clinician's brain should immediately pivot away from pure psychiatry and toward the endocrine system.
That connects directly to the third pattern, sodium and electrolyte imbalances. We touched on this with aldosterone, but even in secondary and tertiary forms where aldosterone is preserved, sodium changes can still occur through different mechanisms related to water balance.
Yes, cortisol also acts to suppress antidiuretic hormone. Without enough cortisol, you can end up holding on to too much free water, which dilutes the sodium in your blood, causing hyponatremia. And hyponatremia itself causes confusion, lethargy, and mental slowing. There is this fascinating case report in the literature of a man who presented with severe treatment-resistant depression and was eventually diagnosed with central adrenal insufficiency. He was entirely immobilized, basically suffering from disuse syndrome. He was misdiagnosed with severe depression. They finally tested him, found low ACTH and cortisol, started him on hydrocortisone, and 6 months later, his psychological symptoms were completely gone. A year and a half later, he was walking again. It was not a psychiatric breakdown. His brain and body were just drowning in a subtle, chronic, hyponatremic and hypocortisolemic state.
The fourth pattern is timing and triggers. This feels like the most useful tool for a patient tracking their own experience. Does the fatigue worsen after physical stress, a surgery, a bad flu, a dental procedure? Depression does not usually crash your system simply because you fought off a sinus infection.
That is the hallmark of physiological depletion. A healthy body sees a stressor, like a sinus infection or a minor surgery, and floods the system with extra cortisol to manage the inflammation and maintain blood pressure. An adrenal insufficient body sees that same stressor, attempts to mount a response, and completely stalls. The tank is empty. The patient might feel generally tired on a Tuesday, get a minor stomach bug on Wednesday, and by Thursday, they are completely incapacitated, unable to get off the floor. That disproportionate crash in response to physical illness is a massive red flag for adrenal insufficiency. It is the body saying, I have absolutely no metabolic reserves left.
Which leads into the fifth point, response patterns over time. If a patient goes to therapy, does the work, takes the prescribed antidepressant, and their mental state improves, but their physical capacity remains completely anchored to the floor, the original diagnosis has to be questioned.
I'm not sure we can even say their mental state improves in that scenario. Or rather, maybe their coping mechanisms improve. They might learn how to manage the frustration of being exhausted better through therapy. But if the underlying cause is a cortisol deficit, no amount of cognitive reframing will restore their stamina. And the danger of leaving this unaddressed is not just a reduced quality of life. The delay in diagnosis, often stretching into months or years, frequently ends in an acute adrenal crisis. That is a life-threatening medical emergency. Blood pressure bottoms out. Blood sugar drops dangerously low. Electrolytes go chaotic. Up to 50% of primary adrenal insufficiency cases are only correctly diagnosed after the patient ends up in the emergency room in full adrenal crisis. We are literally waiting for their bodies to completely crash before we look past the depression label.
I keep getting stuck on the resistance from the medical community here. If the tests exist and the distinction is this dangerous, why are clinicians anchoring so hard to the mental health labels? Why does it take an emergency room visit to get an ACTH test?
It is a matter of frequency and availability bias. Major depressive disorder and chronic anxiety are incredibly common. Primary adrenal insufficiency affects maybe 100 to 140 people per million. Secondary forms are more common, especially with the widespread use of corticosteroids, but they still pale in comparison to the sheer volume of burnout and depression walking into primary care clinics every day. When a doctor hears fatigue, weight loss, brain fog, their brain automatically reaches for the most statistically probable answer. It takes a deliberate, conscious effort to pause and say, wait, could this be the zebra instead of the horse? And in a system where physicians have perhaps 12 minutes per patient, the deliberate pause rarely happens.
The article pivots beautifully toward the end, focusing on the patient's internal experience, this idea of gentle empowerment. It tells the reader to hold space for both possibilities, that the body might be physiologically underpowered and that emotional strain can exist directly alongside.
That is the most vital emotional takeaway for anyone living in this diagnostic limbo. The medical system forces you to choose a lane. Are you a psychiatric patient or an endocrine patient? But human biology does not respect those strict departmental boundaries. When your body is chronically underpowered, your resilience shatters, your sense of identity fractures because you cannot participate in your life the way you used to. That causes genuine, profound grief and anxiety. The anxiety is real. The depression is real, but they are secondary to the physiological collapse. Recognizing that overlap is what finally strips away the self-blame. You are not failing at being happy. Your body is failing to produce the hormone required to generate physical and mental energy.
We have to leave it there, but that framing changes everything. If the experience feels physical, it matters. If it feels emotional, it matters. Taking your own complexity seriously is the first step toward getting the right answers. For anyone recognizing themselves in this, go to the My Adrenal Life Facebook group. It is a space built entirely to help you untangle this exact knot with people who understand it.
It provides a baseline of sanity when the medical system makes you feel crazy.
Find the group, read the full articles, and share this with anyone who keeps getting told they are just tired. The difference is everything.